Okay. Good morning, everyone. Yeah. Today we will be discussing about public health, and we will be giving a whole brief about very comprehensive. We'll be discussing. There will be a lot of data that you have to take down today. So before going into the details, in one of the previous classes, we discussed about this COVID containment models. So while discussing that, we explained, while taking the Indian example, we explained why in the current situation, India has to go for more of taking up the preventive measures than the curative measures. Like some of the preventive measures like this social distancing, lockdown, and these kind of measures. Then because as of now we haven't have any vaccine, and the number of tests we are conducting is still minimal. So this ultimately made us to realize to what extent the public health in India is resilient enough to tackle any kind of diseases or to tackle any kind of infections. To what extent it is resilient to tackle the communicable diseases? To what extent it is resilient to tackle the lifestyle diseases, what we call them as non-communicable diseases? So here, if we have a comprehensive look at the public health in India, then we'll come to know to what extent India is ready to tackle these kind of pandemics. So in that context, I took this concept of public health. So if the students got a better idea of public health, that means the public health indicators in the country, the public health related challenges in the country, and what kind of government initiatives that have been taken till date to deal with the public health in the country. So in this way, if we are able to know, then what I feel is like, okay, it may give a better idea about the public health of the country. So in that context, we have taken up this particular topic. So how the whole lecture goes. So here first we will be discussing, we will be giving a definition of public health, what exactly public health means. Then segments of public health. It goes like this: public health definition, segments of public health, and data associated with public health. Next, challenges associated with public health, governmental initiatives, way forward. So this is the whole broader skeleton under which we will try to fill the rest of the flesh. So then first, see the definition of public health. So this particular definition I have taken from Niti Aayog. So when I was reading that Niti Aayog at the rate India 75 report, in that India 75 report, they gave in detailed information about public health in India. So the definition goes like this. This definition you can take down. Public health is the science. Public health is the science of keeping communities. It is the science of keeping communities healthy. Science of keeping communities healthy through the prevention of disease and promotion of health and well-being. I'm repeating the definition. You can take down. Public health is the science of keeping communities healthy through the prevention of disease and promotion of health and well-being. So this is what exactly the definition of public health. See here, in the given definition, we took two components. One is the preventive side, second one is the well-being of the individuals. So this is what the basic definition of what exactly public health means. So by using this definition, The next, we will be going into the segments of public health. So in what, to what extent we should see public health. So segments, if you see, if you divide what exactly public health, the components of public health, if you see, if you want, you can take in this way also, components of public health. In that, the first one is human resources. Human resources means here we will be having the doctors, ANMs. ANMs means auxiliary nurse midwives. And we used to have these other public health workers like ASHA activists. I think you know the definition of ASHA. Accredited social health workers. Sorry, accredited social health activists. And we have other paramedical staff. So this whole thing comes under the segment of the human resources, the first component. The second component is infrastructure. So infrastructure means here again, we have this medicine, we have the medical equipment, like we have these testing kits, diagnostic tools. These all will be coming under the infrastructure. So infrastructure means here medicines, like availability of the, again you can take it as subcategory, pharmaceuticals. So within that we have these medicines, and we have the diagnostic tools. Diagnostic tools means, you know, scanners, equipments, like diagnostic equipments, like what the equipment that is being used by the doctors. These all will be coming under the infrastructure. And the third is connectivity. And the next component in public health is connectivity. That means to what extent our hospitals are in reach to our public. So in this context, suppose for example, if you see the public health connectivity, so we have the three tier like this. If you take the pyramid, so if you take the pyramid like this, majority of the bottom we have the PHCs, primary healthcare. Primary healthcare, what we also call here as the community healthcare. The major segment of the pyramid is primary healthcare. Next is secondary healthcare. Third one is tertiary healthcare. So if you see connectivity portions here, primary healthcare, secondary healthcare, tertiary healthcare. So the pyramid goes like this. Majority of the portion will be with the primary healthcare, then goes the secondary healthcare, then goes the tertiary healthcare. So primary healthcare means at the community level. So what we used to call them as the sub-centers. Mostly we used to have the sub-centers. At the sub-centers level, it is where these are the primary contacts to the people. So these are the first positions where the people, those who are infected, they will go in contact. Then is the second level, and next is third level at the district level, what we call district headquarters level. Most of the specialized services will be provided at the district headquarters level. So connectivity portion means here we will be discussing about to what extent our public health system is in reach with our public. So again, here we have a lot many deviations. Suppose for example, majority of the hospitals are located in the urban areas. Again, what we call this as the spatial variation. Spatial variation means how many hospitals are there in the urban areas, how many are there in the rural areas, and how many, if you take the whole country, how many hospitals have their presence in the southern states, how many have their presence in the western states, northern states, northeastern states. So this is what we call as the spatial variation. So these all aspects will be coming under the concept of, under the component of connectivity. And the next one is insurance. Insurance aspect. Suppose insurance means, you know, it's a kind of security to the individual, if at all, if the individual has to face any unforeseen situations, like any new any infections or accidents or any other related things. So this is the next segment, fourth segment. So in this way, now if you see the whole public health, so here we divide the public health into the human resource component, the infrastructure component, connectivity component, and the fourth one is insurance component. So these are the components. Next, let's go to the constitutional provisions. Then that's the next point. That's the next point in the given whole list. Transport facilities, yes, that's a kind of connectivity, right? Yeah. So next, if you see constitutional provisions, if you take the constitutional provisions, first let's come with this DPSP. Actually, before going into the constitutional provisions, we can also have one more point here. So we have United Nations Human Rights Commission, UNHRC. UNHRC actually, it classified public health as one of the fundamental human rights. So according to the Human Rights Commission, UN Human Rights Commission, public health is one of the fundamental human rights. Okay. Whereas in the case of India, in how we incorporated this public health into the constitution, if you see, as of now, public health is not a fundamental right. Though we, under the right to life, Article 21, we will derive public health, but as of now, we do not have any declaration of public health as a fundamental right. But in the DPSP, so we have certain provisions, so they deal with public health. Suppose, for example, Article 42. Article 42 of the Indian Constitution, in the Part 4, in the DPSP, in the Directive Principles of State Policy, what it says, we have to provide, that means those who are providing employment, they have to provide just and humane conditions of work and maternity relief. So this is about Article 42. So the state has to provide just and humane conditions and maternity relief to the individuals. That's why we have recently increased the maternity benefits to up to from 12 weeks to the 26 weeks. So right now the maternity benefit that are being provided to the women is up to 26 weeks. So that's why, and by using this DPSP, the state took this responsibility of increasing the maternity benefit of the women, pregnant ladies. The second article is Article 47. Article 47 says, it is the duty of the state, to raise nutritional level. It is the duty of the state to raise nutritional level, health standards, standard of living, and improving public health. Here actually we will be getting the word public health directly in the constitution, in the DPSP. Article 47 says, it is the duty of the state to raise nutritional level, standard of living, and improving public health. So in this way, in the directive principles of state policy, we have the provisions of public health. One is with respect to the maternity leave, maternity relief, and just in human conditions of work. That means we have to provide hygiene and good conditions, a healthy environment for the individuals to work. And 47 deals with standard of living, nutrition levels, and improving public health. So these are the two constitutional provisions in the DPSP. Next, we have the schedules. If you take the Schedule 7, in the Schedule 7, the list system, the union list, concurrent list, and the state list. In that, if you take in the schedules, if you take Schedule 7, in that, if you take union list, entry number 6, I'm sorry, pardon me, in the state list, entry number 6 deals with public health. That's why we say that public health is a state subject. Entry number 6 of the state list deals with public health. Entry number 23, next one is entry number 23 of the concurrent list. Entry number 23 of the concurrent list, it deals with social insurance and social security. Entry number 23 deals with social insurance and social security. That's why insurance component and the social security component will be dealt at both state level and at the central level. That's why we have the state level insurances and we also have the central level insurances. So entry number 6 of the state list deals with public health. Entry number 23 of the concurrent list deals with social insurance and social security. The security component, the insurance component. So these all again we will be discussing to what extent the state is providing insurance to the individual, that we will be discussing in the challenges aspect. So that's why insurance will be dealt both at the state level and also at the central level. Suppose, for example, at the central level we have the employees insurance, ESIC, Employee State Insurance Corporation. So mostly this we have this labor ministry. Labor ministry will deal with this kind of insurance aspect. We have the state level insurances. So next, the third is entry number 29 of the union list. Next aspect is entry number 29 of the union list. It deals with, it is the responsibility of the union to prevent spread of infections from one state to another. It is the responsibility of the union to prevent spread of the infection from one state to another. So this comes under the union list. Okay, so this is about constitutional provisions to deal with the public health. Okay, so then let's come to the some data. Let's take some data, because this data is very important, because once if you get this data, this will be useful for the comparative analysis. So to make a comparative analysis, this data will be useful. So you can get the data. So what kind of statistics we'll be discussing? You can take down that. The first one, if you take the country, take the first point is here, the public health expenditure. Public health expenditure in terms of GDP, as of now, it is 1.25%. It's very bare minimal. So this will be discussing a challenge later. So the public health expenditure in the country is 1.25% of GDP. Next, second point, doctors to population ratio. That means how many doctors we have to the amount of population. If you see the doctor to population ratio, it is right now 0.7 for 1,000 population. Doctor to population ratio 0.7 for 1,000. That means we have just 7 doctors for 10,000 population if you multiply. So in that way, the doctor to population ratio in the country as of now is 0.7 to 1,000. But the WHO is recommending, when it comes to WHO, World Health Organization, it is recommending that there should be 1 doctor per 1,000 population. That means 1 doctor should be there for the 1,000 population. This is the recommendation of the WHO. But whereas in the case of India, still we have less number of doctors when it comes to the population, just 0.7 for 1,000. You know how we will calculate this? 0.7 doctors per 1,000 means just multiply into 10. 7 doctors per 10,000 population. The recommendation is 10 doctors per 10,000 population. But we in India, we have just only 7 doctors per 10,000 population. And nurses. If you take nurses, as of now, the number of nurses per population, if you see, there are 1.7 nurses per 1,000 population. 1.7 per 1,000 population. This, if you want, if you multiply 17 nurses per 10,000 population. 70 nurses per 10,000 population. So, but the WHO recommendation is, WHO is recommending that we should have 2.86. Recommendation of the WHO is that 2.86 per 1,000 population, the number of nurses. This is the recommendation of the WHO when it comes to nurses. Next is number of beds. Number of beds available to the patients. If you see number of beds in the country, if you take number of beds per 1,000 population, here the country's average is 0.55 beds per 1,000 population. If you take the whole country's population, 0.55 for 1,000 population, the total number of beds. But again, here also we have certain variations. Variation means here when it comes to certain states, so we have the number of beds to the population is very high. When it comes to certain states, the number of beds to the population is very low. Take the case of Bihar. Bihar is the lowest. In the state of Bihar, the number of beds per population is 0.11. 0.11 per thousand. Whereas when it comes to the state of West Bengal, it is 2.25. I'm giving this data just for comparative analysis. Later, if you want to write the challenges of public health, this data will be useful. So that's why I'm giving this data. So this data I have taken from the National Health Profile released by the Ministry of Health and Family Affairs. So if you see, the country average of total number of beds per population is 0.55 per thousand, but it is not equal across all the states. If you take the case of Bihar, it is the least in terms of number of beds per population, just 0.11 per thousand population. Doctors 0.7. All right. Whereas in the case of West Bengal, it is 2.25. All right. Again, see here. Let us compare the regional analysis here. If you take the southern states, among the southern states, it is the state of Andhra Pradesh. Here again, while taking up this data, Andhra Pradesh means the undivided Andhra Pradesh. You have to take this into consideration. If you take the case of Andhra Pradesh, the southern states, Andhra Pradesh is lowest among the southern states. The number of beds in Andhra Pradesh is 0.3. 0.3 per thousand population. Whereas for the rest of the southern states like Kerala, Tamil Nadu, Karnataka, in these states, the number of beds per population is above 1.1. 1.1 per thousand population. Understood that? So this is about what you call the number of doctors, number of nurses, and the number of beds available to the population. If you take the 1,000 sample, for 1,000 members, how many doctors are there, how many nurses are there, and how many beds are available? Okay. And the next one is per capita expenditure. If you take per capita expenditure, means the total expenditure on health by the total population. This is what we call as per capita expenditure, right? So if you take the per capita expenditure, again here, if you take USA's per capita expenditure, I'm just giving a comparative analysis, it is 70,000 rupees in terms of Indian currency. Whereas in the case of India, the per capita expenditure, the national average is around 1,000 rupees. It is about 1,112 rupees. Sorry. Yes, 1,112 rupees, 1112, the national average. Okay. In Andhra Pradesh, 0.3. So, if you see per capita expenditure by the total population, if you take, it is 1112. 112. Again here also, though it is a national average, if you see the spatial analysis, again spatial analysis means some states high in expenditure, some states low in expenditure. Take the state of Bihar. State of Bihar again lowest in terms of per capita expenditure. The number is here 491. So the state of Bihar's expenditure, per capita expenditure is very lowest, followed by, again I'm giving the states here, this state of Bihar followed by Madhya Pradesh, Uttar Pradesh. See, these are the states, these are the highly populated states, at the same time low in health infrastructure, and the per capita expenditure on health also is very low. Take the case of the southern states. Southern states, almost all the states, the per capita expenditure is above 1,000 rupees. In that we have this state of Kerala, state of Tamil Nadu. So the per capita expenditure in the southern states is high, and the per capita expenditure in the northern states is low. Let me tell you one more thing here. If you take the case of northeastern states, for northeastern states, the per capita expenditure is very high. Suppose take for example the state of Mizoram. If you take the state of Mizoram, the per capita expenditure is more than 5,000 rupees. Again, if you take the state of Nagaland, the per capita expenditure is more than 2,000 rupees. State of Arunachal Pradesh, the per capita expenditure is again more than 5,000 rupees. But public health infrastructure in these states is less, northeastern states. That's why, though per capita expenditure is one of the tool to measure the status of public health in that particular state, but it is not a measure that is completely effective. Why in northeastern states the per capita expenditure is very high? Because the population is low. You know the formula, right? What is the formula? Total expenditure on health by total population of the state equal to per capita expenditure on each individual. Understood that. So I told you, when it comes to Andhra Pradesh, we have taken the combined data. There is no separation of TS data and AP data. So this is about per capita expenditure. Per capita expenditure, country's expenditure above 1,000 rupees, around 1100, 1112. And when it comes to different states, so we have the variations here. The states like Bihar, Madhya Pradesh and Uttar Pradesh, very low. That's the reason again we can understand the public health infrastructure in these states still is very low comparing with the southern states and the western states. When it comes to northeastern states, though the public health infrastructure, the public health expenditure is high, the per capita public health expenditure, but still the other public health infrastructure facilities are very low. So this is what we can compare. So this is about public per capita expenditure on public health. Next is we have, you can use this data. We have this National Health Index. National Health Index, it will be released. It was actually released by the Niti Aayog. So this National Health Index also you can see this information later. National Health Expenditure, this National Health Index given by Niti Aayog, it actually categorizes the states, larger states and the smaller states. Among the larger states, the best performers are Kerala, Tamil Nadu, Punjab. These are the three best performing states. And the least performers, again down ones, Bihar, Uttar Pradesh, Madhya Pradesh. So these are the least performers. See, in Bihar, the COVID cases are low. It's because of the number of outward migrants. Migrants in the sense the people who goes to outside the country is very low. That is one of the reasons why it is low. So why our government is agreeing? It's not. See, that's what I'm saying. Where there is the talent always migrates to the best places. You cannot stop that. Okay, so this is about this National Health Index, the top performers and the worst performers. And see, this National Health Index also deals like the larger states and the smaller states. So among the smaller states means to be here we have the northeastern states like this Mizoram and all. Mizoram, Sikkim. So it comes under this National Health Index, and we have this MMR and IMR. MMR, maternal mortality rate, and IMR, infant mortality rate. MMR will be calculated how? The total number of deaths per 1,000 population. So in the given 1,000 population, how many deaths happens during the time of delivery? This is what we call as the maternal mortality rate. So the maternal mortality rate right now, it is around 130. MMR maternal mortality rate is right now 130. It varies actually. It is declining in trend. MMR is actually declining. But the global, the WHO's recommendation for the MMR is 70. WHO's recommendation is 70. It should be at least in that level, but the global average. But whereas in the case of India, still it is 130. Even we have this what we call sustainable development goals. We have 17 sustainable development goals, right? So which goal deals with public health? Goal number 5. Goal number 5 of the Sustainable Development Goals deals with the public health. So in the Sustainable Development Goals also the target is by 2030 the maternal mortality rates has to be reduced from 130 to 70. This is about MMR, maternal mortality rate. Maternal mortality rate. Next is IMR, infant mortality rate. Infant mortality rate, how we will calculate this? Total number of deaths of children during the time of birth by 1 lakh population. So this is the difference. So don't get confused with MMR and IMR. MMR for 1000 population, IMR for 1 lakh population. So right now the IMR data is 42, but the global average is 29. Right now the IMR is 42, but the global average is 29. So see here, slight confusion, pardon me for this. MMR will be calculated for 1 lakh population, IMR will be calculated for 1000 population. So I just interchange the things. That's why the numbers are high. See here, IMR is 42, MMR is 130. So definitely MMR should be lower than the IMR. So MMR will be calculated for 1 lakh population. IMR will be calculated for the 1000 population. So 130 deaths per 1 lakh population right now, MMR in the country, but the SDG target is 70 MMR for 1 lakh population. Whereas in the case of IMR, as of now it is 42 per 1000 population. The target is, the global average is 29 per 1000 population. So this is what, so don't get confused. MMR will be calculated per 1 lakh, IMR will be calculated for 1000. So this is clear. 130 per 1 lakh, not 130 per 1000. So this is about data. Then let's come to the challenges. What are the challenges associated with? Now this is the important concept, because till now what is the data that we discussed? This data we will be using to go for the comparative analysis. Accordingly we will be getting the challenges. That means what kind of challenges the country is facing right now in terms of its public health. Then if you see the first one, as we mentioned, the per capita expenditure, the GDP, in terms of GDP, the public health expenditure is one of the lowest among the top countries. If you see, take the case of USA. USA's public health expenditure on GDP, in terms of GDP, is 18%. 18% of the country is more than $33 trillion GDP. So 18% of it is being spent on public health. Whereas in the case of India, in the given $3 trillion economy, we are hardly spending 1.25% of it on our public health. So this indicates the first challenge. You can make the heading as challenges. The first challenge is low public health expenditure. Low public health expenditure. This is here you can write down in terms of GDP 1.25%. If you compare with the top countries, China 5.5% of its GDP, USA 18% of its GDP, whereas in the case of India, just hardly 1.25%. That's the reason we have this the recent national health policy. National health policy's 2017's target is at least 2.5% we have to spend on public health. Though scholars are saying like we have to spend 6% on public health on an average, but the national health policy's target is at least in the next coming years the public health expenditure should be minimum 2.5% of GDP. But right now it is just 1.25. China, it is 5.5 of its GDP. So that's about MMR, IMR recommendation of WHO. A global average is 29. Whereas for India as of now it is 42. Though it is declining, IMR is declining. That means the total number of child deaths per thousand population is declining, but still it is higher than the global average. Global average is 29, whereas for the case of India it is still 42. Yeah. All right. So for the first challenge, what we discussed here is low public health expenditure. See, whenever you are writing a challenge, you have to substantiate that with your either data or with some kind of analysis. Yesterday, I have seen some of your current affairs notes. I have checked the mail. I have seen some of your class notes. Most of you are writing fine, but some of you yesterday used the word. I mentioned about internet outreach. Some of you mentioned that as internet outrage, not outrage, outreach. And most of you are submitting your class notes. Some of you are not submitting that. We are tracking each and everything. Some of you are smartly submitting day before yesterday's class notes as yesterday's class notes. So this shouldn't be happen next time. So while writing, most of you are writing the running notes very well. This much I can say. I have seen both boys and girls, but some of you are not regular. For those people, we have to take the action that we'll discuss later. But while writing, mention these points. So first point is low public health expenditure, that got over. The second point is see the connectivity. Connectivity again, like what we discussed. Then the presence of hospitals in the urban areas is quite high comparing with rural areas. The number of hospitals in the urban areas is quite high. Even the specialization, most of the tertiary care and the specialization, the reach is more in the urban areas comparing with the rural areas. And second thing, it is even in rural areas also, those rural areas that are near to the urban areas, there it is fine. But take the case of tribal pockets. In the tribal pockets, the connectivity is it's like very miserable. So you have seen one example recently, you might don't know, you might heard about it or not. One person in Odisha, he has to carry his deceased wife on his shoulders to the nearby hospital. This indicates what? No proper ambulance facilities. No proper ambulance facilities. So even when it comes to the providing medicines also. So still, you see, in the case of India, mostly in certain pockets, like in rural pockets and in the tribal pockets, the communicable disease spread is high comparing with the non-communicable disease. This non-communicable disease spread is mostly high in the urban areas. Non-communicable disease means like this diabetes, tuberculosis, this cancer, liver-related complications, cardiovascular diseases, all these becoming under the pollution-related diseases. These what we call all these as a change because of the changing lifestyle. So non-communicable diseases are more in the urban areas compared with the rural areas. If you take the case of the tribal pockets and some of the rural areas, there the spread of communicable diseases is high. But the challenge is vaccines. So timely we are not able to deliver the vaccine. Timely we are not able to deliver the medicines, essential medicines. So connectivity issues. So one challenge is rural-urban challenge. Second challenge is the spatial challenge, the regional challenge. Southern states and the western states. The southern states and the western states better off in terms of connectivity comparing with the northern states. I told you, northern states, these are the backward states. Some of the states, I told you this word Bimaru, Bimaru, Bihar, Madhya Pradesh, Rajasthan, and Uttar Pradesh. These are the somewhat backward states. Even in these states only, so these are the backward states in the financial aspect also, even in the public health aspect also, these are the backward states. To some extent, Rajasthan is fine, but the status of public health in Bihar, Uttar Pradesh, and Madhya Pradesh is very miserable. Public health expenditure also very low, and the doctor to patient ratio also is very low. So these are the challenges. So the second challenge is connectivity related challenge. Rural areas to urban areas, southern states to northern states. Whereas if you take the case of northeastern states, in northeastern states, due to the geographical conditions, there, though the per capita expenditure on health is high, but other infrastructural facilities are very low because of the population density. The population density is very low in the northeastern states. And due to the difficult geographical terrain, we are not able to coming up with good healthcare facilities into the northeastern states. That's the geographical challenge. So if you go for the spatial variation, this is the second challenge, connectivity challenge. And the third point is insurance. Second challenge is connectivity. Third challenge is insurance. This data also again I have taken from the National Health Profile. If you see right now, the insurance coverage in the country. Insurance means we just to mention the entry number 23 of the concurrent list. Both state and center will provide insurance coverage, public insurance. Along with it, we have also the private insurance. If you see the insurance coverage in the country, you will just wonder. 86% of the rural population doesn't have any public health insurance. 86%. Again, for urban areas also, it's not much better. In the case of urban areas also, 82%. 82% in urban areas, 86% in rural areas. So if you combine both, the national average of uncovered insurance is 84%. 86 in rural, 82 in urban. If you take these two combinedly, the average is 84. So 86% of the rural population are they are not covered with insurance. 82% of the urban population also doesn't have any public insurance. So this is about the insurance. This is the next challenge. So the insurance coverage in the country is very, very low. Third point. Second point, connectivity challenges. So this is the third point is insurance coverage in the country. The insurance coverage in the country is very low. If you see 86% in the rural areas, 82% in the urban area for the population doesn't have any public health insurance coverage. So this point we should understand here. So where the country is in terms of its insurance coverage, that means just 14% of the population rural areas covered with insurance, and how much? 18% of the population urban areas covered with insurance. So this is about the insurance challenge. All right. Then next comes to the human resources. Just as we mentioned in the previous data, see the number of doctors and the number of nurses. So the amount of doctors and the amount of nurses and the amount of the presence of beds, the human resources is still very low. And again here also we have the regional, we have the spatial challenge. On one side, the number of doctors and nurses to the population is very low. Next challenge, the number of doctors and nurses to the population is very low. Here you will take this data. Why I gave this data? This is the reason. Whenever you start writing your answers or thinking of, you should substantiate your point. If I say that the number of doctors and nurses in the country is very low, it's a challenge to the public health in the country. But how many? You have to substantiate. Then you will write the point. In the case of India, the number of doctors to population is 0.7. The number of nurses is 1.7. You will substantiate. So the fourth point is low human resources. That means the number of doctors and the nurses to the population is very low. Again, here also spatial variation. These doctors also, the number of doctors, especially allopathic doctors. Allopathic means the modern medicine. So the number of allopathic doctors, their presence is quite high in the urban areas compared with rural areas. So this is one of the reasons. Thus, the challenge in this point is that the presence of the quacks. You know the word quack. Who is a quack? Quack is the one who is not a qualified doctor, but still they will be practicing. Okay, in Kashmir, health infrastructure is fine, though not extraordinary. Still, it is actually improving. It's in that's why in the National Health Index, the state of Jammu and Kashmir is in the state of incremental performance. You can check that National Health Index released by the Niti Aayog. So in the fourth point, in this human resources, the number of doctors, majority of the doctors and the paramedical staff, their presence is high in the urban areas comparing with the rural areas. That's why in rural areas there is a presence of the quacks. That means those people who doesn't even have any professional health practice, these people will go and do the test. So this is the biggest challenge right now. So less quality healthcare is being provided at the rural areas because the presence of the qualified persons are very low, the density. So again here, though on one side the number of doctors to the population is less, in that also majority of the doctors, allopathic doctors, have their presence in the urban areas and semi-urban areas comparing with rural areas. So who is taking advantage of it? The quacks. So this is about the human resources point. And the next point is, we discussed, though IMR and MMR, infant mortality rate and the maternal mortality rate is decreasing, is in downward trend, but still it is higher comparing with the global average. I just mentioned, if you take the case of IMR, the global average is 29, but still in the country it is, yes, some of the RMPs in the rural areas also quacks. RMP, regional medical practitioner. Some of them, they won't qualify, but still they will do the services. So next point what I mentioned is here about this IMR and MMR. Though IMR and MMR is in declining trend, but still this what we call comparing with the global average, it is still very less. IMR global average is 29, MMR global average is 70, but the present one is IMR 42, MMR 130. So these figures will keep on varying. So you can take the average figure. So this is one more challenge. And the next point, this is the most important point. The point here is that in India right now, there is a epidemiological shift. Epidemiological shift. Epidemiology, dealing with diseases. What is epidemiological shift? In India right now, the presence of, that means the number of people who are infected with non-communicable diseases is higher comparing with the communicable diseases. Non-communicable diseases right now occupying 55% comparing with the communicable diseases. That means what are the non-communicable diseases? What we discussed right now? These diabetic patients, and we have this cancer, liver-related diseases, cardiovascular diseases, renal failure, renal disease, that means kidney-related diseases. These all will be coming under the obesity-related diseases. So these all will be coming under non-communicable diseases. So unfortunately, in the country right now, the spread of non-communicable disease is higher comparing with the communicable diseases. Non-communicable diseases occupying 55% comparing with the communicable diseases. So there is an epidemiological shift because by using the vaccinations, by using different kind of these medicines and all, we are able to reduce the communicable diseases. But the challenge right now is the spread of the non-communicable diseases. So this is the point we have to remember. So there is an epidemiological shift from communicable disease to the non-communicable disease. So the non-communicable diseases are higher compared with the communicable disease, 55% of it. So this is the next point we have to understand. Rise of the non-communicable diseases. Next challenge. And the next one is, if you see, yesterday I posted this essay also in that I gave the list of figures. In India right now, we are spending more on curative healthcare than the preventive healthcare. What is the preventive healthcare? What is the curative healthcare? Preventive healthcare means before spreading of the disease, we will be stopping it. Curative healthcare means once the disease spreads, then we will come up with the measures. So right now, which one is better actually? Prevention is better, curation is better. Obviously, prevention is better. Prevention is better than the curation. But right now, unfortunately, India's expenditure, India's public health expenditure, this trend you have to remember. India's public health expenditure and curative healthcare is more than the preventive healthcare. I gave the data yesterday. If you see the essay in that I mentioned, right now we are spending more on curation than the prevention. We are spending just only 8% on prevention, 52% on curation. See the data. We are spending 52% on curation, 8% on prevention. It should be reversed actually. We have spent more on the prevention than on the curation, but we are spending more on curation than on the prevention. 52% we are spending on the curation, just mere 8% we are spending on the prevention. So this is the challenge. So India's healthcare expenditure is more on curation than the prevention, though we know prevention is better than the curation. This is the next challenge. Then the next one is, this what we call this as a nutritional challenge. If you see right now, every day we have this global hunger index. We have this report. More than 200 million children in India, they are suffering from hunger. They are not able to have a proper 2 meals a day. 200 million children. This is why we have this global hunger index, right? So as per this, again, India is 1/3 to the world's children who are having this stunting. Stunting means what we call this stunting and wasting. Wasting means with respect to specific height, you should have a specific weight. Stunting means with respect to specific height, you should have a specific what you call with respect to specific age, you should have a specific height. But we in India, we have a stunted growth. Stunted growth because in the childhood, if you do not get proper nutrition, that means micronutrients and the macronutrients, the height will not be as per the age. So with respect to age, if the height is not there, what we call this as a stunted growth. Wasting means with respect to height, you won't be having a specific weight. So this is what we call as the wasting. So in the case of India right now, so India is having 1/3 of the world's stunted children. 1/3 of the world's stunted children are in India. The stunted population is, the stunted children is very high in the country. It is around 36 million children. Whereas in the case of wasting, it is 25 million. So comparing with, if you see just stunting and wasting combinedly, it is crossing more than 50 million children. More than 50 million children are suffering with stunting and wasting. One of the reasons, lack of proper nutrition during the childhood. Because during the childhood, if you want to have a proper growth of your body cells, you should get a proper nutrition. What we call these micronutrients and the macronutrients. But in most of the occasions, the pregnant women, the laborers, especially those who are in the laborers, they won't eat properly. They will go for the work. That's the reason most of the women suffers with this anemia. They don't have proper levels of blood in their body, and they won't eat nutrient foods. So with that, even the just born child, they also won't be getting sufficient nutrients. So with that reason, there is a stunted growth and wasting more in the children. So India is having more amount of these children suffering with stunting and wasting along with hunger related challenges. So this is one more challenge. So these are the list of challenges we are facing with respect to the public health in the country. So if these are the kind of challenges we are facing, just imagine a situation. So right now, why we have to go for more of this kind of preventive measures for this corona? The reason is that the public health expenditure in the public health infrastructure in the country is not that much resilient to tackle these kind of diseases. And these are the kind of challenges we are facing in the public health. Public stunting means with respect to specific age, you should have a specific height. Wasting means with respect to specific height, you should have a specific weight. If you do not maintain that is what somebody mentioned, BMI, body mass index. If you do not maintain proper body mass index, we will consider that as a wasting. So these are the list of challenges. Then you can take down some of the governmental initiatives. What kind of initiatives government has taken to promote public health in the country? And in that, the first one is, we have a lot of indexes. So we have National Health Index, Global Hunger Index, Global Poverty Index, and Global Health Security Index. And we are at the national level, we have this National Health Policy. So these all this information you can collect. Whenever you need to get data, you can get data from these reports. I have taken most of the data from the Niti Aayog and this Global Hunger Index, Global Health Security Index, and from the newspapers. So the governmental initiatives, you can take down the list of governmental initiatives because you can compare to the challenges how the government is reacting. So when it comes to the insurance, recently the biggest one, this Ayushman Bharat. Ayushman Bharat is one of the flagship initiative of the central government. It contains two components. See here, previously we discussed about the hierarchy: primary health care, secondary health care, tertiary health care. So this Ayushman Bharat also deals with these three. So this Ayushman Bharat is having two components. One is what we call this as the increasing the standards of the subcenters. Subcenters where they will be located. Subcenters will be located at the public health care facility. Sorry, primary health care level, PHCs. So at the primary health care level, we have the subcenters because these are the places where when if any individual got affected, first they will be taken to the subcenters. So right now, under the Ayushman Bharat, the present government, it wants to rename them as the health and wellness centers. The subcenters will be renamed as HWC, Health and Wellness Center. So they want to modernize the health and the subcenters into health and wellness centers, and they want to give them more there will be more facilities that will be provided there. Infrastructure facilities will be given there. So this is about Ayushman Bharat first component, renaming subcenters into health and wellness centers and modernizing them. Second point is providing insurance coverage to at least 5 lakh households. 5 lakh households, 5 lakh coverage of 50 crore households. 50 crore households of the country will be given at least the minimum of this 5 lakh insurance coverage under the Ayushman Bharat. If we enroll under this Pradhan Mantri Jan Arogya Yojana, Pradhan Mantri Jan Arogya Yojana is one of the component of the Ayushman Bharat. So under which 5 lakh insurance coverage, the population that will be covered is 50 crore population. So this is about to increase the spread of insurance coverage, because just now we discussed 86% of the rural population, 82% of the urban population doesn't have the insurance coverage. So to give a push to the insurance coverage, this Ayushman Bharat second component is Pradhan Mantri Jan Arogya Yojana, under which 50 crore households will be covered with an insurance coverage of up to 5 lakh rupees. This will be at the secondary, at the tertiary level healthcare. So at the secondary level, tertiary level, mostly what kind of things will go? Mostly the non-communicable diseases. So for these things, the government right now came up with the insurance coverage under the Pradhan Mantri Jan Arogya Yojana, PMJAY. So this is about Ayushman Bharat, the first initiative. And the second one you can take when it comes to nutrition, to give a nutritional food to the individuals, especially to the children and the pregnant women. Recently, government came up with one what we call this mission, what we call this as Poshan Abhiyan, National Nutrition Mission. This is what this they named as Poshan Abhiyan, Health and Wellness Centers, HWC. So the second initiative is Poshan Abhiyan, under which the government wants to provide nutritional food. Especially it wants to give, that's why, to the pregnant women and children, they will through the ICDS. We have this ICDS, right? ICDS means Integrated Child Development Scheme. We have Anganwadi workers. Anganwadi workers will do this work. with the help of the Anganwadi workers under the ICDS scheme, with the help of the Poshan Abhiyan, government, the central government will be providing nutritious food to the children and the pregnant women. That is Poshan Abhiyan. And the next is in the what you call pharmaceutical sector, we allowed 100% FDA. So we allowed private investments to come in so that more number of medicines can be made in the country. So right now, if you see, India is the world's largest exporter of medicines. So what we thought of is like, okay, if we allow 100% FDI, foreign direct investment into the pharmaceutical sector, more investment will be coming, more medicines can be made in the country. We can not only export, so we can also be use them for the country's population. So this is about next one, the third point, 100% FDI in the pharmaceutical sector. ICDS full form, Integrated Child Development Scheme. So that's about the next point, the third initiative. Next, recently, to make the medicines available at the lower cost. That means to make the medicines available at the lower cost, we came up with this initiative, what we call this as Jan Aushadhi Kendras. Jan Aushadhi means medicine, right? Jan Aushadhi Kendra. So there all kind of generic medicines will be available at the lower cost so that the people can go and purchase from these Jan Aushadhi Kendras. So the Jan Aushadhi Kendras provide what you call generic medicines at a very lower price to the population. Because right now, if you see medical shops and all, mostly they have their presence is high in the urban areas, not in the rural areas. So these Jan Aushadhi Kendras will pay their attention in the semi-urban and the rural areas, through which it will be through these Jan Aushadhi Kendras, government is selling the generic medicines. Generic medicines means, you know, the medicines that are at the lower cost and not branded medicines. And the next one is we have this Mission Indradhanush. You know, Mission Indradhanush. We have these diseases like DPT, diphtheria, pertussis, tetanus, measles, mumps, rubella, Japanese encephalitis, poliovirus, hepatitis B. You can see the list later. DPT, diphtheria, pertussis, tetanus, measles, mumps, rubella, Japanese encephalitis, poliovirus, hepatitis B. So these are all these diseases will be covered under the program called as Mission Indradhanush. Initially, it used to have the what you call simply it as Mission Indradhanush means universal immunization program. Under this universal immunization program, we have this Mission Indradhanush. Through Mission Indradhanush, we are providing vaccine to these kind of diseases: DPT, diphtheria, pertussis, tetanus, MMR, mumps, measles, rubella, and we also have this Japanese encephalitis, poliovirus, hepatitis B. So for all these diseases, for all these infections and diseases, we are providing the vaccines under the Mission Indradhanush. MMT, not MMT, MMR. Mumps, measles, mumps, and rubella. These are all communicable diseases. Rashes on the body, fever, and all. So next one is we have this what you call this promotion of this telemedicine. Right now, extensively we are using that telemedicine. We are using right now. Like telemedicine means along with this tele-education, we have this telemedicine. Like doing operations by staying in the urban areas, they will be guiding the public health officials in the rural areas to provide medicinal services, like giving treatment online. So we also came up with some equipment. The doctor, but see, I will be here. The doctor will be, suppose for example, this is a kind of live interaction. The patient will be somewhere. The doctor through here can see the symptoms of the patient because the equipment will be attached like that. Through the equipment, the doctor will be getting the indicators. That means how much fever the patient is having, what kind of problem the patient is having. For most kind of common problems, through tele things, that means through the live, the doctors also will come to know. So it's about this telemedicine, promotion of the telemedicine. And when it comes to this mother and children, especially for the women, we have this, they recently government came up with this initiative called as Suman. Suman full form means Surakshit Matritva Avasan. Matritva Surakshit Matritva Avasan. So Avasan is assurance. So under this Suman initiative, government is providing like zero cost healthcare facilities to the pregnant women. So zero cost healthcare, that means high quality, low cost, zero cost healthcare facilities to the women in the public facilities. Remember, not in the private hospitals. Zero cost, high quality public healthcare facilities to pregnant women in the public health facilities. This is the initiative, Suman initiative. Along with this, we have this Pradhan Mantri Matritva Vandan Yojana. Pradhan Mantri Matritva Vandan Yojana, PM Matritva Vandan. What we call this as Pradhan Mantri Matritva Vandan Yojana is a maternity benefit scheme. So if any woman is in who is in carrying stage, they cannot go for work. So for this woman, government will provide some kind of financial assistance. We will be providing when during her delivery time, they will provide the transport facilities. And because she is carrying right now, she can't go for work. Government will give some kind of financial assistance. Government is providing 5,000 rupees. 5,000 rupees will be provided to the pregnant women under the scheme called as Pradhan Mantri Matritva Vandan Yojana. So these are some of the schemes. So these are schemes with respect to the women. For children, we just mentioned ICDS we have. So it is one of the successful schemes. It is to provide nutrition facilities to the children. And along with that, we have this one. What we call recently we thought of this bridge course, that means Ayush doctors. Now government is extensively promoting this Ayush courses. You know Ayush full form. Ayurveda, Yoga, Unani, Siddha, Homeopathy. So because everywhere we do not have this allopathic medicine, so government now wants to promote this Ayush also. Ayush means Ayurvedic, Yoga, Unani, Siddhi, Homeopathy. So that if you promote traditional medicine, so in the places where the allopathic medicine is not available, there you can also use this Ayush, this traditional medicine. So for that, in the National Medical Commission Bill, government thought of this bridge course for this Ayush people to promote them as a doctors. But due to the resistance from the MBBS doctors, government dropped this idea. Along with that, we have some success case studies. Suppose take for example Andhra Pradesh. In Andhra Pradesh, we have service called as 104. 104 is mobile health service. So there is a 104 van that will go from village to village in a period in time base. Suppose for example, on every third day, the 104 van will come to that particular village. So the villagers, they no need to visit any public health facility. Just by visiting that particular mobile van, the ambulance, it's a kind of ambulance. It's not actually ambulance, it's a kind of mobile van. So by visiting that mobile van, they can get some essential medicine. Suppose if they're having some kind of fever, cough, cold, by visiting that 104 service, they will be getting their basic things done. So this is a kind of mobile facilities. The state of Andhra Pradesh is doing that. It's a very successful model. And government is actually, some of the state government is coming up this what you call mobile ambulances. This what you call motorcycle ambulances to reach to the hinterlands, because the places where you cannot reach the normal ambulances, we are trying of these motorcycle ambulances. So these are some of the initiatives of the government. So there are lot many minor initiatives also. I have just taken some list of it just to give you an idea of what kind of initiative the government is taking with respect to promotion of the public health in the country. Yes, the name that has the Talli Vidya Express, right. Dream IAS is right. So that is actually 104 service. It was actually started during the time of Rajshekar Reddy, 104 service. Now the name that has the Talli Vidya Express. It's a very good initiative actually. So the mobile van will be reaching to the villages like for 2 days or 3 days. then the services will be provided. In most of the cases, the rural areas, they will be having common problems like some knee pains or cough, cold, fever, diarrhea-related diseases. So these are the common problems there. So for all these things, they will be providing the medicines. So these are some of the government initiatives. Then next, you can write the way forward. Way forward means for all these problems, you have to provide the solutions. Way forward means what you will be writing here. Better connectivity should be there. We have to increase the healthcare professionals. We have to increase the per capita expenditure. We have to increase the country's GDP. GDP per capita expenditure of in terms of GDP should be increased. Suppose, for example, the national health policy it wants 2.5% at least. So way forward means for all these challenges you will be writing the solutions. So in that way, right now, I hope you got some idea with respect to what exactly public health means, how many components will be there in the public health, what way you have to collect the data. See, I have given very comprehensive data here. This data you can use. This data may vary, but the components will not vary. So every time if you have this whole structure, you can update the data. So that's why I have given a comprehensive coverage of public health. What is public health definition? Components, governmental initiatives, challenges, constitutional provisions, way forward. So this is the whole macro level framework of what exactly public health means. So with that, we will wind up the session. So I hope everything is clear. Any questions? If not, then I will wind up. So I am winding up then. Thank you. See you on Monday. Tomorrow, I think you guys will be having exam. Get ready for that. From these 4 components, I will be giving the questions. I think we just covered 4 components in the week. Only on what are the 4 topics we covered. From these 4 topics, only questions will be given. Right. Thank you.